Hello, everyone. I'm Dr. Nina, Executive Director of TOVA Community Health, and I am here today on Your Health Matters, TOVA Health TV, to talk to you about the importance of sickle cell warriors getting access to a kidney transplant. I have some experts, community advocates, and a renowned transplant surgeon here, Dr. Scantlebury, and a sickle cell warrior from the state of Delaware, the first to receive a transplant for his kidneys, and the difficulty in the journey of 6 years to get to this point. And so I'm so excited to have our guest here today. So stay tuned. Mr. Bailey, how are you today?
I'm doing pretty good.
Do you want to be called Mr. Bailey or Mr. Ladaris or Barely Ladaris?
Ladaris is fine.
Okay. I know you by Kevin.
Yes.
But Mr. Ladaris, you have been on the transplant list for 6 years, 6-year journey of doing home dialysis. But can you talk to us about how you got to that point? What happened?
Well, as you know, I have sickle cell SS, and attempting to manage the sickle cell was going pretty well. I had a number of intense crises 1 year, and each time I was hospitalized, my kidney function was less and less. I was hospitalized at Presbyterian in Philadelphia, and my hematologist at the time was Dr. Roy Gay, who was an expert on sickle cell. And the last time I was hospitalized, my kidneys actually seized, so they weren't functioning. And so I had to go on dialysis while I was in the hospital. I didn't know at the time that it was going to be a continued process, but it was. And so that's how I ended up on the renal transplant list.
Yes, and so the sickle cell crisis and not getting enough oxygen and perfusion to the kidneys impacted your kidneys over time, as well as other organs as well. But Mr. Ladaris, before your kidneys stopped working, you had a vibrant career. You were a graduate of Morehouse College. You were working in the nonprofit sector. Can you talk about that?
Yeah, after graduation, I was very lucky. I immediately started working for nonprofits. I'd worked in assisting homeless people. The job that I had when I actually went into the hospital was working with homeless vets with the program called Impact Services, Veteran Services in Philadelphia. And my job was to make sure that veterans who had served this country were housed, properly taken care of, making sure they got their resources and benefits. And so it's, a pretty intense job. And so I was working, 8-10 hour days and doing perfectly fine, still managing the sickle cell with the help of TOVA and my hematologist. I had some issues with high blood pressure, but thanks to TOVA, I was doing pretty well. Those numbers were coming down. And so I didn't think that it would be an issue. And so when I initially got sick, I thought that it was just a normal crisis that I would go through. And then the doctors came in and said, hey, look, we are having some problems with your kidney function. And that was the first time I was hospitalized. And then I think about a few months later, I had another crisis and went in and the kidney function was even less. And so that's when I found out that, I was having severe kidney problems. There were really no warning signs for me at the time because I was working and doing well. And it just kind of hit me by surprise. But, when I was in the hospital and they told me I had to do dialysis, I immediately jumped into it. I had dealt with the sickle cell for years. I knew that process. And my biggest concern was how that was going to affect the sickle cell.
Right.
And I knew that I had to monitor the fluid intake. I had to monitor my diet. But turns out that the limits that you have with renal failure in terms of intake of fluids really affected the sickle cell because my body wasn't getting hydrated as much, and it just caused even more damage.
Right. Yes. So this is definitely a complicated process of having to do dialysis, having had problems with hypertension in the past. I think over the last 6 years, I must say that even in the state of Delaware, there has been a huge investment in resources for sickle cell, an educational training of being more culturally sensitive when someone, especially of an African American male, comes into the emergency with crisis, that there should be a standard of care in place to make sure that you're getting blood work checked, making sure you're getting hydrating, you're getting appropriate pain medication to keep you comfortable. Can you talk about that one emergency room visit where you came back twice, they just gave you some pain medicine, sent you out the door, blood pressure was up, didn't get any fluids, didn't get blood work checked? Do you think that had anything to do with why you're in this situation, that you're in the situation that you
Yeah.
were? Do you think anything could have been done differently? We're not
Well,
blaming, we're just trying to
yeah.
understand how we can prevent these type of
Well,
problems from happening.
I do think that one of the biggest issues, and I've had this my entire life, when you go into the emergency room with a sickle cell crisis, you have to deal with the first thought that you're med seeking. The second thought is that they don't really quite understand how to treat sickle cell, especially if they haven't had a lot of sickle cell patients. And so throughout my history, I've always had to take a moment and kind of explain the process while I was in the emergency room. And I always thought that it was unfair. Like I'm in the middle of a crisis and I have to actually sit down with the doctor and kind of walk him step by step on how to handle it. Hey, I need an IV. I need this much fluid. I'm going to need the pain medication after that. After that, that's going to put me to sleep. I'm going to sleep for about an hour and then I'm going to need this. And so it's a weird process to have to kind of educate folks on your own care. And I think that the process of me going through that was difficult, but I also think that it added to the difficulty managing the renal failure because I think that a lot of the doctors were attached to dealing with the renal failure without knowing how to deal with the sickle cell.
Mm-hmm.
And it was a long process, but once I knew that my kidneys had failed, one had seized up, and that I was going to have to be on dialysis. I figured out, I did a lot of research on that process, and I had gone in center for the first, I think, 2 years. And then I decided that I'd much rather do it at home because I wanted to continue working, and started that process. I immediately got on the transplant list at Penn and was going through that process, the stress test, the blood test, getting ready for a transplant. And then I was sidelined. I got a call after going through all the tests and being approved to be on the list. And I got a call saying that I was going to be placed on an inactive. And I wasn't quite sure what that meant. She said that I would be on the list. I would still accrue time. However, I wouldn't qualify for a transplant. And that was very difficult to hear because I had been on the list for about a year at that point. And so she initially said that my hemoglobin was too low, which is the nature of anemia.
And sickle cell, right? For some people, yes.
And so they wanted my hemoglobin to be at least 10 10.5. And throughout my life, my hemoglobin had always hovered around 7, no more than 7.5. And so I thought that was going to be very difficult. And so we were working on increasing the hemoglobin level. The hemoglobin level actually did increase. And so I was placed back on the active list. This was after about a year. So a year's time goes by and I wasn't qualified for a transplant. And so I was really happy. About 8 months after I'd been placed active again, I got another call saying that I was placed on inactive again. And at that particular point, I was so frustrated because I didn't understand why I was still going to be placed on the inactive list. I decided, with the advice of TOVA and my hematologist at the time, Roy Gay, that I would apply for the transplant list down at John Hopkins. And I had gone through the process of entering that. I had gotten a call from the University of Penn, and it was a consortium of doctors who wanted to explain why I was inactive. And I was a little aggressive on the phone because I didn't understand that process. And I was telling them, hey, look, I understand your concerns, but I am very healthy. I've been healthy throughout my process with sickle cell. I can go through this transplant. And they were like, well, no, we just want to be cautious. We want to do a few more tests. And I get a call back after that discussion from one of the interns. And she said, well, is there anything else you want me to tell the committee? And I said it, really aggressive. I said, look, I need you all to be brave and attempt to do this transplant. I said, one of the things that I got out of the phone call was that I think that you all are afraid to do it because you think that I'll fail. And I think that you all are afraid that your numbers will drop because you'll have a transplant. And I'm telling you, that is not the case. I can go through this transplant. I'm healthy otherwise, other than sickle cell and renal failure, and I can do it. And they were like, well, we'll take that into consideration. And I never got a call back.
Wow.
They never placed me on active again. And so I was lucky enough to be on the John Hopkins list. I went down from Wilmington to Baltimore several times to do the stress test, echocardiogram, the blood work. And, they were very willing to work with me. They had worked with sickle cell patients before. And I felt like they were willing to take the chance on doing the transplant. And sure enough, I was right. They they did the transplant. It went well. The first few weeks were difficult because the kidney had not kicked in. My body was so used to not drinking water that was the holdup. Like I couldn't get enough fluid in my body for the kidney to kick in.
Wow. So Mr. Ladaris, just quickly, we're going to hold off on that because we want people to listen in so they can hear the ending. But I want to bring in Dr. Scantlebury to answer some of the questions why doctors are afraid to list people with sickle cell. But Dr. Scantlebury became the first female African-American transplant surgeon in 1989 and worked tirelessly over her career to increase minority access to transplant. It's done many, many transplants on hundreds of people, improved their quality of life, did my godfather's transplant. We actually had to talk about that as well. But I want to bring Dr. Scantlebury in to talk about some of these disparities, especially we're focusing today on sickle cell, but also some of the politics of getting a kidney. The numbers of people who need kidneys is extraordinary, but then there's, access seems to be an issue as well. And there seems to be a lack of understanding about sickle cell in general, that they can have just similar survival rates as anyone else that needs a transplant, as we know with this new study that was just published. But welcome, Dr. Scantlebury. How are you today?
I am doing well. Thank you for having me. And it's a pleasure to meet you, Mr. Ladaris, and to hear about your success with your new kidney. And so congratulations to you. And the fact that you have such a great outcome. Yeah. So since May, right? You said May. Yeah.
You
So
got the
thank you
call
for
in
having me.
May.
Yeah.
During
Yeah.
COVID. Like, woo. Dr. Scantlebury, why did you want to become a transplant surgeon? It seems like you could have done a lot of, went in a lot of different areas, and that seems so specialized, but it seems like you have such a passion for service.
Well, I knew I always wanted to be a surgeon once I hit medical school, and that is something that I enjoyed. And I have to say, my exposure to transplant just sort of came incidentally because my goal was to become a pediatric surgeon, and in doing that, I had to do research. And so my research was in transplantation surgery, and that allowed me to see a whole different field that I was not familiar with. And at the end of my training, I realized that pediatric surgeons didn't do transplants. And as a transplant general surgeon, I had the ability to do both adults and children. And so I initially started out doing multi-organ transplantation. And with the realization, especially looking at African Americans and the disparity when it comes to kidney transplants was much more apparent because of dialysis and the renal network system that gathers all the data on patients on dialysis. And you're able to see that the numbers, the disparities that existed in terms of being 13% of the population, but nearly 35% of those awaiting transplant, and probably even more on dialysis because of for African Americans, the main cause being hypertension. But overall, the number one cause for kidney disease is diabetes. And because most of us as an African American know somebody with diabetes or hypertension, and knowing that those are the two leading causes, we begin to have a greater population of people with chronic kidney disease. And so many people with chronic disease who don't know they have chronic kidney disease. And a lot of our patients end up being acutely diagnosed with end-stage renal disease without even knowing they were headed in that direction. Because basically the symptoms are silent, and maybe fatigue that we all complain about. You don't lose your urine output, so you may not know your kidney is failing. You may have anemia and feel tired. And so just as we were hearing from Mr. Ladaris about being anemic, that's in itself is a symptom or side effect of kidney disease. And so we end up with a disproportionate number of people awaiting transplantation because the need is great, but it isn't matched by organ donation. And it isn't matched by organ donation in the communities of color, in the African American community, as we still struggle. We are disproportionately on the list awaiting transplantation. And even though we've had increases in organ donation, we don't match being a third of the people who donate. And so that continues to be a point of education to really embrace people of color overall, and to get people to understand that donation saves lives. It saves lives, and it brings a better quality of life to so many others. And so when you think about a person like Kevin, who waited 6 years for a transplant, 10 years ago, we used to say the waiting list was 3 to 5 years. And gradually over time, it's increased. And now we say 6 to 8 years because more and more people are added to the waiting list every day. So it's very unfortunate, but we still need to realize that, yes, sickle cell disease, as you was hearing from him, when you have sickle cell disease and you end up with kidney failure, knowing that sickle cell disease also causes damage to so many organs because you have clotting and areas that are obstructed in different organs. And just as your kidneys will go, you worry about the other consequences of sickling in other organs. And so the disease itself isn't going to be impacted by getting a transplant. It's about really looking at the other complications of sickle cell that transplant centers are concerned about that will continually exist. Just as your kidneys are damaged because of sickling, we're looking at how do we keep the new kidney from going through the same process down the line, and how do you slow down the process of sickle cell disease affecting other organs. So generally the choosing of candidates is really looking at how complicated their different end organs have been affected by sickling, to say, well, will this kidney last and not be subjected to the sickling process again?
Wow. Thank you so much for that, Dr. Scantlebury. And me as a primary specialty care provider and a sickle cell expert as well, you touched upon a couple points that I want to just enumerate on, and that diabetes and hypertension are huge contributive factors for individuals ending up on dialysis, developing chronic kidney disease. But I don't think that people really understand the function of the kidneys as well, Dr. Scantlebury. I'm just going to say a few things, and then I want you to elaborate more as an expert in this area. So the kidneys, the function of the kidneys are to filter out waste products, foods, medicine, and toxic substances in the body. And it also helps regulate blood pressure, and it also helps produce red blood cells through a hormone called erythropoietin as well. And it regulates fluid balance. And it is really important for those who have high blood pressure or diabetes to make sure that their blood pressure is well controlled, as well as their diabetes, their hemoglobin A1C is under 7. So that means making sure you have your wellness checks at least yearly, getting blood work done, to check your numbers to make sure that you have good blood flow and perfusion to your kidneys, because as you know, with the sickle cell crisis, when there is a lack of oxygen, nutrients, and blood supply to the kidneys, over time that causes damage. But Dr. Scantlebury, can you chime in on that as well? Any other thoughts about that?
Oh, absolutely, because it is important. One of the things that we worry about as patients become anemic is that you're not delivering enough oxygen, as you said. And not only can that lead to what we call cell death, as it occurs in many different layers, whether it's the lining of the tubules of the kidney, whether it's in your heart, whether it's in your brain, that becomes an essential component of keeping your cells alive. And the consequences for patients who are anemic suffer cardiovascular issues and are more at risk for heart attacks or brain damage. And so you want to maintain appropriate hemoglobin. And as your kidneys become diseased, you don't make as much erythropoietin as you would normally. And as you said, even if you didn't have high blood pressure as your cause of kidney disease, high blood pressure is also a symptom of kidney disease. So once you develop chronic kidney disease, you will suffer from high blood pressure, because that is also a symptom. So you didn't have to have it in the beginning, but once you develop kidney failure, that becomes an issue of monitoring and being able to make sure that it's taken care of. And as you said, many people don't see the kidney failure or recognize it, because your kidneys are filtering, but it's putting out water, but it's holding on to the metabolites that it's not able to excrete. So patients will say, well, I'm still urinating. And you says, yes, but that urine doesn't contain or isn't really filtering out the necessary things. And it's hard for people to understand that, why are my kidneys not working? I'm still going to the bathroom. And once dialysis takes over and begins to cleanse your body, then you make less and less urine over time, because there's no need for the kidneys to struggle to put out that same amount of liquid as before. So it's really important. But then as you get on dialysis, you need to restrict your volumes, because you are now at a point where after some time, for some people it may be months, and for some people it may be years, before 1 or 2 years, before the urine output gradually decreases. And this is for hemodialysis in particular. And so as you put out less urine, you cannot drink as much, because then your volumes are affected by, you need to take off that fluid once you get to dialysis. And with sickle cell, that makes it even more difficult, because you then are subjected to more complications from sickling and sluggish cells, and therefore you get more crises or complications as a result of being restricted on your volume. And for some patients, if they don't have many abdominal issues, in those cases, peritoneal dialysis may be something to consider, because it doesn't allow, it gives you less volume restrictions. And so those are things to consider. So it makes your case more difficult being on dialysis, not being able to have that volume that you require because you're on dialysis and no longer, and have to restrict your volume.
I will say that Mr. Ladaris has done a fantastic job for 6 years. Dr. Scantlebury actually did his dialysis at home 3 days a week.
Okay.
He trained himself, and the nurses came to his house to do it. And he was such a warrior. And I know that there's times where it was difficult, with the fluid. If too much was taken off, and it would drop his blood pressure, he would feel really tired. And just, the stress of having to do that all the time on a regular basis is just to be applauded. But I also want to just chime in on what Mr. Ladaris said in regards to the doctors at the center in Pennsylvania were afraid to put him on the list for a transplant. And so, Kevin, can you talk a little bit about that, and as far as, do you see that as a health disparity, or do you think it's just that the doctors don't really have an understanding of sickle cell? And then we're going to talk about this new research and data that just came out in 2021 from the research team at John Hopkins, that showed that the survival rates for those post-transplanted were similar to the general population. But can you just talk about that from your perspective, and then we'll have Dr. Scantlebury weigh in on it.
Well, from the beginning, I thought that there was some caution about adding me to the list. I think that there are two things. I think that there is a misunderstanding about the process around sickle cell and renal failure. I think that a lot of doctors have a surface knowledge about sickle cell, but I don't think that they understand it in a way where they can trust that the body can go through this surgery. I think that they think it would be difficult because of what Dr. Scantlebury said. I think that sickle cell affects so many organs in the body that I think that part of the concern is the complications after surgery. And as much as you reassure them, I think that, can be a legitimate concern. I also think that just as any medical organization or any organization at all, you are concerned about success and you're concerned about your numbers. And I think that they choose candidates they think have a better chance of being successful because, their funding, their reputation, all depends on successful transplants. And I think that anytime that there may be a possible failed transplant
or funding, Dr. Scantlebury, right?
it can affect, their reputation, their funding, their ability to recruit, better candidates for doctors, everything. And I think that all of that played into why, it was so difficult for me to be on that list. I think that because John Hopkins had experience in transplanting people with sickle cell, I think that they were less concerned about a possible failure. And I do think that that's the case. And I mean, I had this conversation with Penn before leaving their transplant list, and they never responded to it. So,
But I think now that we have this new data and that this could be a game changer for those living with sickle cell who may need a kidney transplant. But Dr. Scantlebury, I wanted to get your perspective on this as well, but I also wanted to share with you some of the data that was just published in the Clinical Journal of American Society of Nephrology, and this was just published in 2021. Can you see the screen here? Can you guys see?
Not yet.
Here? Okay, I'm sharing it now. So this was just published in 2021, and it also looked at a database registry from the United States Renal Disease System from 1998 to 2017, so almost 10 years of data. But it did show that having sickle cell disease can affect the chances of someone receiving a kidney transplant. But of those waitlisted candidates, only 27% were likely to undergo a transplant than patients without sickle cell. But overall, which is most encouraging, the survival rates for those with sickle cell who received a transplant were almost similar to those in the control group. Can you talk about that, Dr. Scantlebury? What are your thoughts about that?
I'm sure. I do have to say that a lot goes into making the decision to transplant someone. And not everyone that gets on the list will be as healthy as Mr. Ladaris. And as someone who has done transplants in sickle cell patients, you have to understand that this data is a collection of data from various transplant centers over a range of time. And because collectively, one center isn't doing this. You're looking at centers who may have done 1 or 2 or 3 as you begin to understand that the numbers of patients who present for sickle cell with sickle cell for consideration of getting on the list are often complicated. And there's certain criteria from each transplant center that says, how many hospitalizations have you had? What are other organs have you affected? How many infections have you had? And certainly in my experience, we've had to take patients off the list who were sickle cell, who have sickle cell disease because they were constantly in the hospital with crisis every 3 months and every 6 months. And so you have multiple hospitalizations per year. So what's happening to the rest of the body is also important in considering someone who is getting a kidney transplant. So you can't lump everyone together and say that the outcomes are in generally, you have to say that those who were selected to receive a transplant were the creme of the crop because they likely did not have repeated hospitalizations. They likely did not suffer multiple complications of sickle cell that leads to why many patients with sickle cell don't survive long-term because they suffered complications. So when someone gets to the list, it's because you feel that they will, not only do you have to be selected to say, will you keep out the hospital? Will you survive the time on the list? And so many others are taken off the list after they've been on the list because of the complications that they continue to have because of the underlying disease process. And you can't forget that. Mm-hmm. That we are not changing the sickle cell process. We're just trying to provide them with good kidney function, despite the fact that they're still going to have sickle cell disease. Mm-hmm. And they're still going to struggle with all the complications of sickle cell disease. And so when you come to the table and present yourself and you're complicated, or you've got multiple complications already from sickle cell disease, that is a predictive factor of whether you will be alive in 3 years or 5 years or 10 years. And if you have to be on the list and you don't have a living donor, knowing that you then weigh the risk that, yes, we know that the mortality of being on dialysis is going to likely make your sickling worse, but there may be options to look at other modalities to where home dialysis is a better option, or peritoneal dialysis, to minimize the complications from dialysis, because you're challenged with the complications from sickle cell. And will you be alive in 5 years? Will you, waiting on the list and doing well, or will we end up taking you off because you end up in a severe crisis, intubated in the ICU, and are not doing well? So those things have to be taken into consideration. And so with each center, they may, it's not necessarily reputation, because putting a kidney in is putting a kidney in. It's what happens after you put the kidney in, and how do you prevent that disease process from getting worse or even advancing. So kidney transplants for sickle cells, the patients are not done singly. It's done in conjunction with a team of people who manage sickle cell disease. So while you're doing the transplant, the management of that patient continues with the sickle cell expert, because they know how to deal with crisis. They know, and so it's a multidisciplinary team. So it's not necessarily that they don't have experience with sickle cell disease. It's dealing with how can we minimize those complications that's going to jeopardize your kidney after the transplant. And the goal is not losing that kidney after the transplant to sickling, if you've continued to have crises, depending on how do you manage those crises. And so if you're in the same boat or the same situation, despite getting a kidney transplant as you did before, then we haven't changed anything except gave you a kidney that is doomed to not do well, because you still continue to have these severe complications.
Wow.
And so when you look at each center, you're looking at, one thing is that mentioned in this article, and I may have forgotten, is how many transplant centers contributed to these 181 patients that eventually went through the study. And if you look at it, it may be a whole lot. We have 297 transplant centers. When I was at the University of Pittsburgh for 15 years, during that time there, we might have done 4 sickle cell patients, and the outcomes weren't great because of the complications that occurred at 3 years and 2 years. And so they may make it past the 1 year, but it's continue to prevent the disease processes down the line. So in defense of my colleagues, I'm going to say it's not necessarily ignorance, it's being challenged to say, how will this kidney do, and how can we, with the team who manages sickle cell, have some predictor to say, is your crisis under control, that we're not going to damage this kidney or have it end up scarred from the same process that killed your original kidneys.
Right. And I will also say, and I would say you would have to look at each patient on individually,
Yes.
as you were saying, and look at their overall health. And for in defense of Mr. Ladaris, is that he really never had a lot of sickle cell crisis.
Right. So that's different.
He really, and it was more of the hypertension and also kidney starting to have stress, but also making sure that, there was good blood flow and perfusion, that they were hydrated at a time of a crisis. Seemed to be some miscommunication and misunderstanding with the emergency room as well as the hospital list as well. But I also want to say that there are a lot more disease-modifying therapies, Dr.
Right.
Scantlebury, to treat and manage individuals with sickle cell that we've never had before. So voxelotor and quixazolizumab, and hydroxyurea, which has been around a long time, and even putting people on chronic transfusions to just take sickle out of the picture is very important. But also, as you were saying, preventative care. You can live well with sickle cell. So making sure you have your wellness checks, making sure you know what your numbers are for your blood pressure, what your kidney function is running, as well as your hemoglobin A1C, to make sure your diabetes is well controlled. And I would also say from this talk, it's really important to try to find a transplant center that would be willing to wait list you. Maybe if you get denied from one center, there's lots of, you said there's 297 transplant centers in the country, to find one that would be willing to take you on. And sometimes, like you said, the bigger academic institutions have the resources, have done more, and they may be willing to take you on. That this is a long road, like you said. I was thinking 6 years ago that probably 3 years ago you would have a kidney. I didn't realize it would be such a long road for you. And so just staying positive, keeping on the road, knowing that we're in your corner and we're fighting for you behind the scenes, doing whatever we can to make sure that you have that opportunity. If you need therapy, you make sure you have a good support system from your family is very important. And as Dr. Scantlebury said, you have to have a good team of healthcare providers around you. It's a multidisciplinary approach to helping those with sickle cell who need a transplant. You have to stay adherent to medical appointments. And I will say that Nurse Rosemary, there's a transplant coordinator at Hopkins, became my BFF. And every 3 months I would check in with her and just have a call and say, hi, how you doing? And has he had his echo done? Has he had his cardiac stress? Are we missing any labs or any diagnostic studies? And she would go through and say, no, but he hasn't had his dental appointment yet. Oh, got to get on the phone. I got to give him a call, have my nurse call. And I know, Kevin, it was, you didn't like to hear from me, but they are looking to see, like Dr. Scantlebury said, are you adherent to your medical care? Because all of that weighs in when they make the decision if a kidney comes available. Well, yeah, you'll be on that list active and to be able to, when that call comes, that you can go. So yeah, I really didn't realize that, but Dr. Scan, want to weigh in on that as well? Yeah, a lot of things behind the scenes that happen.
Yes, I just want to also make that you can be on 2 separate regional lists. Like University of Penn is in one region and Hopkins is in another. So you can be on different centers as long as they're not in the same region. So you can multi-list. You didn't necessarily have to come off of Penn's list unless you chose to do so. But because John Hopkins is in a different area, if you have found someone, say Temple or Jefferson or someone was willing to list a patient, then you can also be on the University of Maryland or Hopkins, but you can't be on Hopkins and University of Maryland because they're in the same region. It's and let's say you have a friend and you wouldn't want to go to New York because the waiting list there is 10 years. But let's say that you have someone a family member who lives on the other side in Pittsburgh. That's an option to consider because that's another region. As long as you're able to get there and as long as you're able to follow up with the clinic visits and the postoperative care. So that's the issue in multi-listing, is that the distance sometimes can be financially expensive.
Wow. Thank you so much. So Kevin, can you tell us how you're doing today?
I'm doing great. I'm doing great. And I think that, being on dialysis was a long road, but I felt comfortable doing it myself. I can put the needles in my arm and function, and doing hemo at home was a positive for me because I could still work and function the way I was used to. My traveling was limited, but at least I was healthy. And I'll say this, as resistant as I am to doctor's appointments and everything, I really appreciate TOVA. I had all of my vaccinations. My dental clearance was done. I had all of my necessary exams, stress tests, blood work. I had everything done. TOVA kept on that. The advocacy part was really crucial once I got the call. I got the call at 3 a.m. in the morning saying that they had found a kidney and I had to be at the hospital. I rushed to the hospital, and that first day I was there prepping for surgery. They had received a call from TOVA saying, hey, he needs a pint of blood before the surgery, and they were rushing to get that. They had all of my medical records. They had all of my pain regimens. They had everything ready to go by the time the surgery happened. And after the surgery, the follow-up care was amazing. And so I have to say that being in a position where I wasn't hospitalized a lot, and that I got all of my medical clearances done. I think that added to why I was able to be selected for a transplant. And I really appreciate that. And right now, the kidney is functioning. I'm healthy. My blood pressure is normal. And I haven't been through a pain crisis. So I'm pretty happy right now. And as long as I don't have to do dialysis, I'm good to go. So
Thank you
Awesome.
so much, Kevin. And I hope you can be an inspiration to others and to continue to share your story. And we wish you much health, wellness, and success. And we're in your corner. But I want to end with Dr. Scantlebury. You had a long career, saved many, many lives, improved the quality of lives of many people who needed a transplant. You could have went in another area of surgery, but you chose kidney transplantation. With this new data, with Mr. Ladaris being the first Delawarean with sickle cell to get a transplant, what is your hope for the sickle cell community and others that need a transplant? And then my second part of the question is, how do we reduce the number of people that need a transplant on the list? What can we do as primary care providers to keep patients with chronic kidney disease as stable as possible?
I think it's important to have healthcare providers that are able to recognize patients who are at risk, and we need to start with preventive care. If we know someone has diabetes or hypertension, depending on whether or not that's something that can be reversed, or depend, especially if it's type 2 diabetes and it's not the, I mean, yes, you may have a familial tendency, but oftentimes making sure that there's enough education about your hemoglobin A1C and the importance of controlling your diabetes. And both high blood pressure and diabetes are silent diseases. Because they don't have a lot of symptoms, people don't think about it.
Mhm.
Oftentimes I chastise my family members if they go on a trip and they forget their medication. How can you forget your medication? Well, I'll be okay if I don't take it for a day or two. No, it's
I'm
not.
fine. I'm fine.
It's not. I feel fine. Doesn't necessarily equate to what's going on the inside. So knowing the importance and taking ownership for your disease processes and making sure that you are on a plan to improve your overall health is really essential. Working with your providers, seeing your doctor, not skipping your medication. And if you cannot afford it, let it be known. Say, I can't afford this. It's something cheaper that I can use to help me. If you abandon taking that medication, you're only injuring yourself. Just remember, your doctor is off doing something else. So who's paying the price for that? You are paying the price for that, and your body is paying the price for that. So prevention is key, understanding what's going on in your body, and get on a regimen that will lead to better health. And one of the things I say for patients, even as they come forward to be evaluated for kidney transplant, is even if they do not get on the list, they now have been given recommendations to say, here are the things that you can do better. Here are the things you can do to extend your life and your quality of life. And I understand that those things are important, taking care of ourselves before we get there. And if those diseases aren't avoidable in terms of end-stage kidney disease, understand your choices early on. Understand whether you will do best with a transplant. Are the people in your family who are friends who may be willing to donate? And this is where educating others is important to building that trust and also having more people willing to be organ donors so that we can save more lives.
Wow, thank you all for coming on TOVA Tuesday, Your Health Matters. I have learned so much, and I'm so just grateful for having clients like you, Mr. Bailey, to have really forged along with some very tough situations and staying positive through this whole process. And we're really in your corner and wish the best for you. But I also want to thank Dr. Scantlebury for coming on and having such an impactful career as a transplant surgeon. I'm just an honor to have both of you here. And I hope that many, many of people can hear this TOVA Tuesday and really learn the importance of prevention, but also understanding that even with sickle cell, you can live well. And we hope that those who have end-stage renal disease, that they have the opportunity to be transplanted as well. Again, I want to thank you all for coming on TOVA Health TV. And this is Dr. Nina. To follow us and to hear more stories and episodes, please go to our website at www.tovacommunityhealth.org and like us on Facebook and Instagram. If you would like to make a donation to TOVA Community Health, you can donate on our Cash App, which is $TOVA Health, or PayPal at contact@tovacommunityhealth.org. Thank you all for coming on TOVA today. And I'm so grateful to have so many people in the community that are doing such great work, and we must continue on. Thank you.
Thank you. Have a great day.
So.